Yeah, hi everyone. Thank you for the introduction, Rochelle. I'm very happy to be here, and I feel like this is one of my most important presentations, I guess, because it's really talking to patients. Yeah, so I'm just finishing up my master's. Actually, I have maybe like around 4 months left. I'm defending in a couple months. And this was my master's project. And this is also kind of a bigger initiative that our lab took, where we again looked at two therapies to kind of improve the more psychological aspects to sexual health and intimacy, not only in patients after prostate cancer, but in their partners as well. So it was really a couples study and couples intervention. And I work for UBC Sexual Health Lab, and my supervisor is Dr. Lori Brotto. So she is a pretty well-known sex researcher, but she mostly does women's health. So this is kind of like a unique study for our lab. And also throughout this, we partnered with, as Rochelle said, Vancouver's Prostate Cancer Supportive Care Program. It's an amazing program, and I'm going to provide some information and resources linked to the program at the end of this presentation. Yeah. So I guess I'll start off by giving some background around why we chose to study this and background information that I learned on prostate cancer in Canada and kind of the side effects and the psychological aspects of it. And then I'll walk through what we did for our study, and then kind of what our main takeaways were and how you can actually practice these therapies at home if you choose to, or if you have any interest in them, how you can learn more. Okay. So as most of you may know, prostate cancer is very common in Canada. It's estimated to affect 1 in 9 individuals or Canadian men within their lifetime. And then to be more specific, locally to British Columbia, where the study took place, this was kind of the BC Canada's report from 2021. So they haven't released one for 2022 yet, but I'm assuming it'll be quite similar. In 2021, British Columbia's cancer program estimated that around 3,600 British Columbians would be diagnosed with this disease at the end of the year. So fortunately, prostate cancer has quite a high survival rate in Canada. And although this varies by province, there's around a 93% 5-year survival rate for the disease, which is great. However, treatments for this cancer leave individuals with a lot of symptoms and a lot of side effects, many of which can be long lasting. So when you think of, like, again, high incidences of cancer with a high survival rate, but coupled with treatment side effects, there's a lot of people who then require supportive care. So the most common symptom after prostate cancer treatments, they usually involve bowel, urinary, and sexual dysfunction. And this differs by type of treatment. Sexual dysfunction is actually the most commonly reported symptom. And it's also reported to be the most distressing symptom after prostate cancer. The most talked about and kind of well-known sexual dysfunction side effect is erectile dysfunction, which really differs between treatments, but it has been reported with all treatment side effects. So one example is a study conducted in 2017 that looked at 2,500 men who had received some sort of prostate cancer treatment, including active surveillance, which is just where you don't actually go through any medical treatment and you just keep track of your PSA levels and your prostate cancer risk over time without actually treating it. So in this study, this was done in the US, and we found that over 3 years after radical prostatectomy, at that 3-year point, only around 43% of these patients who had radical prostatectomy were able to maintain erections sufficient for intercourse. Around half of radiation patients were able to, and actually around 75% of active surveillance patients, so those who had no actual medical treatments, were able to have erections sufficient for intercourse. So even if they're not having any treatments, there's still like a higher rate of incidence of erectile dysfunction compared to the general population. And one study also looked at like 12 years with men who had only active surveillance, and they still had higher rates of erectile dysfunction than their same age non-cancerous population. So the way we actually currently treat this sexual dysfunction is commonly through erectile aids. Patients are often prescribed like Viagra, Cialis, or Levitra to promote blood flow. However, these often don't work too well, especially if you have like any sort of radiation treatment or radical prostatectomy, because there's tissue damage. So the next step in erectile aids for those who wish to, treat this would be vacuum erection devices, or penile injections prior to sexual activity. And these are actually very successful. Like one study found that vacuum devices had around a 92% success rate, and the injections had around an 85% success rate. So they're very good at actually maintaining erections. However, a lot of people stop using them. In that one study, around 80% of people, or 85% of the participants, stopped using their aids altogether. So we do have these very successful kind of medical treatments for erectile dysfunction, but they're actually not being used. And so a lot of researchers decided to investigate this and interview prostate cancer patients afterwards. And kind of they found that the reason that they were being discontinued in both gay men and heterosexual men is that there was an artificial feeling, is that they felt unnatural, that there was kind of a loss of spontaneity of sex, so it wasn't really worth it. And there was also quite a bit of discomfort and pain with use. So what we learned from this is that there's also more going on than just the medical treatment. So there's a higher rate of depression and kind of low mood and psychological symptoms in patients after prostate cancer. Prostate cancer patients have higher depression scores than the general population. These depression scores were worse when the men reported lower sexual satisfaction. They're also more likely to have low mood when they have unmet sexual needs, and sexual dysfunction directly affects their quality of life. At least that's what has been found in the research. So then when we actually interview, when we actually look at like people's experiences and we interview these patients, one of the biggest themes that really comes out of research is that sexual dysfunction is never purely medical and never purely 100% mechanical. They discuss that sexual dysfunction impacts their mood, it impacts relationships, it really impacts self-esteem and even a sense of identity as a man. And many prostate cancer patients who were interviewed said that this psychological aspect of sexual health was often left unaddressed. And it's evident that when I look at actual research, there's few psychological therapies to treat sexual dysfunction in this population. So this was a quote from an interview. This was a study done in 2017 that I thought was really lovely. It says, there's a fixation in care on erectile dysfunction because you're not a dog, you're a person. And what you actually stop is you stop feeling sexy. What you want physically from someone changes, so you don't have that kind of sexual feeling that is linked to getting erection. But the erection isn't the be all and end all. So what we kind of looked at was kind of how it impacts people psychologically, and how the medical and sexual dysfunction is really more than just a physical thing that happens. But another thing is that this really impacts partners as well. So doctors and researchers both describe prostate cancer as a couples disease, and this is because it really just impacts the partner just as much in some cases as the patient. So there's been a lot of research on female partners of those with prostate cancer or those after prostate cancer. And what they found is that these female partners reported high levels of depression, of anxiety and distress, as well as worse overall sexual functioning and worse overall sexual satisfaction compared to a cancer-free population. And then more recent studies have started interviewing gay men and have found similar patterns. They found that gay partners of men with prostate cancer found that the sexual dysfunction really impacts both of them, and that partners are really big supporters and carers of the patients as well. So what we learned from this is that any type of research or any type of care, when we can, should involve both prostate cancer patients and their partners. So when we look at all this background information together, we see that there's a pretty big need for some sort of therapy that addresses the kind of sexual health, but really the emotional aspect of this sexual health after prostate cancer. And that this also addresses the couple as well as just the patient. Past information that has studied kind of psychological therapies has found that usually when these therapies involve some sort of like peer supportive or group environment, couples tend to have better improvements in their mental health as well. So my lab historically, the UBC Sexual Health Lab, has looked at female sexual dysfunction and female sexual health, or sexual health in women. And we've looked at two psychological treatments a lot. mainly mindfulness therapy, but also cognitive behavioral therapy. And I'll explain those in a minute. And what we found is that we can use these therapies and create interventions for women that are really successful at helping them deal with sexual dysfunction that they may face. One thing in particular is that we found in quite a few studies that mindfulness therapy has really helped women improve their sexual function after gynecological cancer. So given our lab's history in doing this, and then also we're very close with the prostate cancer supportive care program. We're actually right in the actual physical building that we work in. We're like right beside each other in the hall. So given this research and also the prostate cancer supportive care programs kind of work in the field, we decided to partner with them and to apply to a Movember Discovery Foundation grant. And we received this funding, and when we got this funding, we decided to study these therapies at a large scale in couples who had received a diagnosis of prostate cancer in the past, had also received treatment for this prostate cancer, or were undergoing active surveillance, and who are experiencing some sort of sexual dysfunction or problems with intimacy. And so our goal with this was to help improve the overall intimacy and sexual relationship of couples after prostate cancer by addressing kind of the more psychological and relationship or relational aspects of sexual dysfunction. And then on top of that, we also are getting to evaluate these two therapies in a new population, in couples after prostate cancer. So cognitive behavioral therapy is a type of psychological treatment that focuses on identifying and challenging negative thoughts and behaviors. So an example of practicing cognitive behavioral therapy is you could write down your behaviors or reactions in response to a situation and try to look at them and approach them more objectively. CBT has been actually studied in prostate cancer populations. So what we found in a few studies is that cognitive behavioral therapy, or CBT, has improved self-esteem and masculine self-identity after cancer. It's also improved anxiety and distress in family caregivers of patients. So it has actually been looked at in kind of partners or any type of family caregiver of prostate cancer patients. It's also helped men cope with a very unique symptom after prostate cancer, which is hot flushes. And a couple studies have also found that CBT has helped men improve sexual health and kind of sexual satisfaction after prostate cancer. So one study found improvements in sexual satisfaction directly after they gave cognitive behavioral therapy, but they didn't look at any long-term follow-ups. Another therapy, and these were small scale studies, these are pretty small studies, but another study found that a mix of therapy and a mix of sexual health kind of education for couples and for men alone really improve sexual satisfaction long term. However, these studies, again, were both really small and they weren't compared to a non-treatment or control group. So it doesn't have that extra strength and evaluation to see if it really causes a change for someone compared to someone who's not undergoing any type of therapy. So mindfulness, on the other hand, is kind of a type of meditation or a therapy where you practice present moment, non-judgmental awareness. So this means trying to intentionally bring awareness to your thoughts, feelings, and bodily sensations in the moment as you're feeling them, and doing so without placing any judgment on them, like thinking about what your feelings should mean or what they should be. So past studies have looked at mindfulness and prostate cancer, and they found that mindfulness has helped improve mood and quality of life in patients with prostate cancer. It's helped improve a person's actual immune responses, which was very cool after practicing mindfulness for a while. It's also helped prostate cancer patients after their treatments maintain healthy diets. And this is great because it kind of seems like it's very good to add to other types of regimens or other types of educations or treatments. Unlike CBT, however, no one in the past has examined mindfulness for sexual health or sexual satisfaction. So prior to this study, our lab actually conducted what's called a pilot trial. So this is when we had a small number of couples, we had 14, and we saw if mindfulness practice would improve their sexual outcomes. And what we found is that in those 14 couples, when we tested this therapy at a smaller scale, these 14 couples, after this mindfulness practice, they reported long-term improvements in their sexual satisfaction. So given those results, we then along and tested both of these therapies at a much larger scale in a group of couples. So this is the goal for our main therapies, where we're now testing our main study, where we're now testing cognitive behavioral therapy and mindfulness. So we wanted to look at the three things. We wanted to look at their kind of psychological aspects to their sexual outcomes, so their sexual distress and their sexual satisfaction, and also their relationship satisfaction. And this was kind of our main, our primary outcomes. And then we also wanted to see if mindfulness or cognitive behavioral therapy would improve psychological outcomes like anxiety, depression, distress, or quality of life. And then we decided to also look at whether there were any changes in sexual function or sexual activity following these therapies. And so this is what happened in our studies. We had 75 couples. These couples were those who had received a diagnosis for prostate cancer, were experiencing some sort of sexual dysfunction, and had underwent prostate cancer treatments or active surveillance. And what they did is they answered questionnaires on their sexual distress, satisfaction, relationship satisfaction, and all those variables that I mentioned. And then once they answered those questionnaires, they were either underwent 4 weeks of cognitive behavioral therapy, 4 weeks of mindfulness, or just no treatments. They're placed in the control group. And these therapies, what they had to do is they had to come into 2-hour sessions a week of psychological therapy. And these were in groups of couples, around 2 to 6 couples per group. And so they come in and do that for 2 hours each week. And then on top of that, they had around 30 minutes of homework to complete each night. And once these 4 weeks ended, they were then, we then waited 6 weeks, and then we got them to answer all those questions again. And then 6 months later, we reached out to them again, and then we got to answer all those questions. So the 6 month is to see if these outcomes are really lasting long-term. So this is what actually happened in our study. So we had, in both groups, we had them complete general sexual health education. So our participants learned about sex and intimacy. And we also had them do a type of sensation activity as a couple. And then in the CBT group, they learned what CBT is, and they completed a lot of handouts. And then in the sessions, they discussed these handouts. And then in the mindfulness group, they did in-session meditations, and then they also had meditation practice. So here's an example of the sexual education that we gave. So this is what's called the sexual response cycle. And I won't go into detail with it, but it teaches us that there are several ways and reasons to have sex. So the goal is really to teach participants that there are several reasons to have sex that don't normally start with simply having desire, and that desire and arousal can come into the cycle at different times. So the idea is to start teaching us to broaden our definition of sex and intimacy, and to consider sex as more than just a spontaneous activity. We also instructed couples to participate in Sensei Focus. So this is a touching exercise where couples touch each other's bodies in different stages without progressing to actual sexual intimacy. So the goal of this is to really get couples to get comfortable with each other, to understand what feels good for which couples, and to build intimacy without actually having the pressure of having sex. For cognitive behavioral therapy, our goal was to get couples to really break down their thoughts and thought patterns, and to learn, so this is an example where they learned what different types of negative thought patterns are, and then how you can recognize them, and then when they actually occur, how to deal with them. And then we specifically apply those to the context of intimacy. So here's an example of catastrophizing. So this is when you kind of think of all the bad situations that could happen. And the way you deal with this is to deal with the event, not the imaginary consequences of the event. So that's just one example. On the other hand, mindfulness participants, so again, they practice meditation each session instead of learning about these thoughts and filling out worksheets. And the goal of this meditation was to train the brain to stay in the present moment. And each week they learned a new meditation. They're also required to practice 30 minutes of formal mindfulness training each day. So they had 30 minutes of meditation, and they were given recordings of these meditations to do. And they were also encouraged to do 10 minutes of informal mindfulness each day. So this means just trying to be very mindful and to try to apply that like present moment awareness while doing a daily task. And the goal is that while staying in the present moment, you're able to then apply that to sexual intimacy and stay in the present moment during sexual intimacy. So these were the participants in our study. We had 75 couples. Our average participant was white, well-educated, and an average of 65 years old. Almost all our couples were either married or common law, and they'd been an average of 28 years together. We also had 3 couples. We had 71 heterosexual couples, and then we had 1 couple where the survivor was non-binary. And of those 75 couples, we had 75 prostate cancer patients. Most of them had received a radical prostatectomy. And then a lot of them had received multiple other treatments. So the second most common was actually androgen deprivation therapy. And then within that group that received radical prostatectomy, around half of them had full nerve sparing, and around 30%, so a third, had partial nerve sparing. And then we had a small number that were unknown. On top of this, we had 4 participants that actually just underwent active surveillance only, so they didn't have any of the actual medical treatments. And then we had 1 additional participant who was receiving chemotherapy for their prostate cancer. And just a reminder, so what happened in our study is, again, they completed their baseline measures, and then they were either in the cognitive behavioral therapy, the mindfulness, or just no therapy, so they just control. And then 6 weeks later, they repeated the surveys again, and then 6 months later, they did the surveys once again. And so here are results. So this was kind of the biggest thing we were looking at, is this idea of sexual distress. So this is when you're feeling upset, or like having really upsetting thoughts or distressing thoughts around sexuality and intimacy, either during sex or when you're thinking about sex. And this is all the couples together. And what we found is that couples in the mindfulness group in particular had less sexual distress 6 months after the treatment from their baseline measures compared to the control group. So on this graph, higher numbers means more sexual distress. So obviously we want to lower that number. And when you look at the control group, you can see that there's really no changes. And actually at 6 months later, their sexual distress increases. And then when we look at the mindfulness group, and the CBT group has a similar pattern, but the decrease in sexual distress is not as much. But in the mindfulness group, the sexual distress really decreases 6 months later. So this means that this was maintained long-term. When we looked at relationship satisfaction, there was actually no changes in any group, but what we found in all 3 groups was that there were small changes or small decreases in relationship satisfaction over time. So even in the non-treatment group, control group. So we think that there's something unrelated to treatment going on there that's kind of more indicative of the general population for prostate cancer, for couples after prostate cancer. And then we call this survivor sexual satisfaction. So we looked at this separately from the partners, and this is because this is a measure that's used a lot in most prostate cancer studies, and that also we have different scales for men and the female partners. So we looked specifically at the sexual satisfaction of the prostate cancer patients. We called it survivors here. And what we found is that in the control group, there was pretty much no changes in sexual satisfaction. And this was on a scale from 0 to 6. So the control group, there was only very small increases in sexual satisfaction over time. There weren't any big changes. In the mindfulness group, we can find that 6 weeks after the treatment, there was improvements in their sexual satisfaction, but this wasn't statistically significant. So the change wasn't big enough from their baseline for us to really think it's due to treatment. But in the cognitive behavioral group, there was a bigger change from their kind of baseline measure to their 6-week measure, indicating that the treatment was really the cause to improve their sexual satisfaction 6 weeks. Unfortunately, this was not maintained long-term though. So then we looked at kind of our second hypothesis, which was the more psychological aspects of this. And what we found is there's actually no changes in any of the psychological outcomes like anxiety, distress, and depression. And we also did not find any changes in their physical kind of health, their physical quality of life. But we did find changes in this domain of quality of life called social and relational. So these are questions based on friendship, but there's also questions based on kind of like satisfaction with sex and satisfaction with their romantic relationships. And what we found is that the control group actually maintained relatively similar levels over time, and they actually decreased in their social and relational quality of life over time. In the mindfulness group, there was a small increase at that time too, but it wasn't big enough, it wasn't significant. And then in the CBT group, there was a large increase in social and quality of life 6 weeks following treatment. And so we recorded this as statistically significant because it was a big enough change that it wouldn't be accounted to by chance. And unfortunately, again, this was not maintained 6 months after the CBT treatment. And then interestingly, we found this one effect in this domain of quality of life called environmental quality of life. So this means people's quality of, or their satisfaction with their environment and their sense of being safe and secure in their environment. So like their housing. And one of the biggest questions in this scale was in access to healthcare. So we think that maybe this was due to improved access to healthcare by participating in the study. And what we found is that in the CBT group, there were small increases in this over time. In the control group, this actually decreased over time. And in the mindfulness group, there was a big enough change, although it looks quite small here, where from their baseline to 6 weeks after treatment, there was greater environmental quality of life. And then when we looked at sexual function and sexual activity, there was actually no changes over time, no really changes due to treatment. So this is an example of, we recorded like their amount of times that they spent doing non-penetrative activities. We thought this might increase because this was kind of what we were encouraging with our intervention, is to kind of go away from the idea of traditional sexual roles and to kind of approach sexual intimacy as a more holistic pleasure-based activity. But unfortunately, we did not find any changes in their sexual activity. And in fact, we found that both their penetrative and their non-penetrative sexual activities that I put in this slide ended up decreasing over time for both groups, for every group. So those were our main findings. And then what we did is we also interviewed participants at the end of the study. So at that 6-week follow-up or 6-month follow-up, although it kind of more so depended on the participant availability, we interviewed them in the groups to see what they thought about being a participant in the study. And what we found is that around 61% of the interviewees who participated in the mindfulness intervention believed that they had better sexual function by changing their beliefs of sex and intimacy. And then 50% of the interviewers, so around half of those that we interviewed or that agreed to be interviewed that participated in the CBT intervention, believed the same, that they had better sexual function by using CBT. And then around 65% of these participants also discussed the importance of having their partner involved and open to the study. So we knew that we did well by including couples. And then here are some quotes from our study. And this is something that stuck out to me is one of the things that came up in these exit interviews was there wasn't a way to really practice this outside of the study. So a lot of people kind of fell off in a way because they weren't able to practice or access these therapies after the study had ended. So I really like this last quote where someone in the CBT group, sorry, it should say survivor CBT group, and they said that what changed during those 4 weeks is that we actually did our homework. So someone actually held them accountable. I would have to say that the impact on us was excellent during the course, but we definitely have fallen off. And so this kind of got me thinking that, so the main takeaways here, I'll discuss the main takeaways first, is that We found that mindfulness long-term can help couples deal with feelings of distress surrounding their sexual function after their prostate cancer. And that cognitive behavioral therapy, after it ends, in the short term, it can improve both sexual and relational outcomes of the couple. And then most importantly is that survivors and partners, for the most part, believe that the interventions actually improve their sex lives and intimacy. So anyways, this is what I wanted to talk about. So I was thinking about how, well, there's a belief that these interventions work, and there's past evidence that mindfulness and CBT in general can improve psychological health after prostate cancer. And then our evidence kind of shows that there's an improvement in sexual health. So I wanted to make this kind of available to patients. And so I'm going to stop sharing my screen and I'll show you what I did. But so if you're not familiar with the Prostate Cancer Supportive Care Program, they have both in-person clinical appointments with sexual health nurses and workshops that you can attend after prostate cancer, or kind of even they have some stuff for the beginning of your prostate cancer journey that really covers all aspects. Like they have pelvic floor physio. They're just a fantastic program. And they also have a really great online website, and this website has different modules that include clinicians or pelvic floor physiotherapists or psychologists kind of discussing different stages and different information after prostate cancer. And so once again, I decided to work with them. And then I'm just going to share my screen really quickly. We created some tools to actually educate and share these resources in the program. So the first thing I created was kind of this patient handout. And this is just to give to patients in the program or to get referred to. And it discusses basically what mindfulness is, what CBT is, and then what our study found in terms of looking at these for sexual health. And it also discusses kind of the past benefits found in mental and physical health with these therapies. And then we have this end section. It's if you want to learn more about mindfulness and CBT in our study and how to practice these techniques at home, you can visit our website link. And it's actually a clickable link. So this gets sent to patients over email. And so let me show you what the website looks like. So we actually created a website. So this is what the link will send you to when you click on it. So the website actually contains a 20-minute video of me. And here, I'll pull up a section of it. And the most important part of the video is it talks really about the mechanics behind mindfulness and CBT and how it can improve sexual health. And then it talks about how you can practice these therapies at home. So what goals you should set and how you can access them. So this is an example of how I discuss practicing mindfulness. And then when you scroll down, there's a little blog that just kind of summarizes what's in the video. And then when you get to these sections, so how can you practice mindfulness and CBT? For each section, there are website links to websites set up where their meditations are available. So you can go on and you can practice meditations. Or for CBT, if that's something that's more for you, is to really work on worksheets. You can go on and access website links that bring you to CBT worksheets that you can work on your own. And then we also have some additional books if that's something that patients would like to explore. Okay, so that is my presentation. Thank you so much, everyone.